Thank you very much indeed for the very, very kind invitation and introduction. It's a pleasure and a great honor to be here, coming from a very tiny, small country far away. That you found it on the map, it's amazing to me. Here I am, and I'm here with great pleasure. I'm going to talk you through two parts of my talk on viability with PET, CT, and PET. And the first part will cover a little bit the background and the protocols, and the second one will go into cases and clinical importance and some clinical aspects. Now, I took this slide here from the ASNC, from the American Society of Nuclear Cardiology website. There is what they call a practice guidelines card, where they give you a little bit of background and some indications, and also a little bit of advice for technicians also how to run a cardiac PET, and I think that's certainly an interesting source. I would like to go a little bit more into depth and remind you that post-ischemic heart failure is due in more than 60% of cases to coronary artery disease. So it's heart failure due to left ventricular dysfunction following an ischemia and an infarction. And there is evidence from non-randomized studies that if we revascularize these patients, we improve their outcome. There is a little bit of prognostic prospective data, and I will try to cover that as well. In patients with the ischemic cardiomyopathy and reduced systolic function, we aim at improving the regional and global function and the prognosis at the end. Where does this all come from? In the 70s, when they looked in the angiogram, they found eventually in some of the patients that areas which were not contracting after an extrasystole and after epinephrine was going back to contractility. So they realized there are substrates of myocardium not contracting, but not dead. It's then later on it was called hibernating myocardium. It's just, it doesn't get enough oxygen to live and contract, but it's just a little bit too much to die, and it's somewhere in between. It has been then publicized by Raham Tula with the term hibernating myocardium, which is this substrate which has a reduced ventricular function to match the reduced blood supply. There has been lots of discussions whether resting flow is decreased or just the hyperemic flow, and I would like to take you through this thoughts. I think it's not important whether the baseline flow is dramatically reduced or not. The interesting part is, at the beginning, probably if you have a lesion, your hyperemic flow decreases, so your flow reserve, your needed increase to match your increased oxygen demand will be lower, and then eventually your resting flow also decreases when your contractility declines, and somewhere in between your hibernation then starts to be active. From these trials here, where they have started doing revascularization in a very broad population, they have realized that patients who get revascularization, if they have reduced ejection fraction, do have a better outcome. However, if you take all these studies together and you look how much they improve their outcome, they have prolonged their lives by a length of about 10 months in average, if they had decreased abnormal left ventricular function. However, only a minority of patients in all these trials had a reduced ejection fraction. So this is based on relatively small numbers of patients. If you look, for example, at one of the larger one, not so impressive high number of patients, that's the CAS registry, they have found that the upper curve with their surgical treatment does better than the medical one. Now, if we go into more details and check the different stratifications of ejection fraction, then you will see that those with impaired ejection fraction, of course, benefit, but those with even more reduced ejection fraction, here the difference gets larger, and those with very low ejection fraction, you'll realize that the difference here gets bigger and bigger. So those with the poorest ejection fraction have the most benefit. However, these patients are at the highest risk of having events during surgery because they're patients with very low ejection fraction. So in these, it is very important to be sure at the beginning of the decision-making of a surgical strategy that they will indeed have a benefit out of that. And if we take together all the studies which try to see whether surgery is doing better or whether medical treatment is doing better, you will see that almost all of them, except for very few, are favoring surgery. Most of them, however, all of these data are retrospective. There is, of course, a lot of bias, because if you select patients who are better for surgery, then of course they do better with surgery. So these were hints telling us that probably there is something behind it. There was this trial as well, which showed that for a couple of years after PET FDG, you are doing better. If you have an early intervention, your mortality is much lower. And then at the end, and that's something that is very important to realize, the curves of whatever treatment, whatever disease you take, the curves at the end merge for the simple reason that people at the end of their life tend to die. Now, which patients would need evaluation of viability? This is a strong and very schematic algorithm, which is not 100% covering daily life, but I think you have to realize that we are talking about patients with low ejection fraction. And I got patients referred for FDG scanning with normal ejection fraction. They tell me, have a look at their viability, and I tell them, that's nonsense. They send me patients with open coronary arteries, and I must tell them, look, this is not a good indication, because the aim of that evaluation is to decide to open an occluded artery. And if the artery is already open, there is little we can do. Now, we have to look for patients with reduced ejection fraction, and we do have to look for patients who technically can be revascularized. If the interventionalist and the surgeons tell us we cannot touch this patient, then there is no way of doing further evaluation. Now, if this is all fulfilled, then we look for further things, and the first step is we check whether they have angina. If they have angina, they have jeopardized myocardium, which is ischemic and which deserves revascularization anyway. If they do not have angina, then we look for ischemia with an ischemic test. We take, in my country, we have done a lot of research on PET perfusion, but it's not yet reimbursed because the officials and the authorities usually have not a lot of knowledge about medicine, so they think, okay, we do a little bit of administration, and then they say, well, PET is new and is a bit more expensive, and to cut the story short, it's not reimbursed, so we're not doing a lot. SPECT has a very broad database. We know a lot about it, and it's the most widely used test. Maybe it will be replaced by PET, we don't know. But at the moment, we do perfusion scanning mostly with SPECT, or we do it with MR, and a few we do with PET, because when we know that we probably have a triple vessel disease like here, and then we would like to see the increase and the lack of increase. If there is signs of ischemia, the patient should undergo revascularization. If, however, we cannot detect any ischemia, because, for instance, we use SPECT instead of PET, and we have these problems that we just saw. We have no increase in flow, or we have microcirculatory dysfunction, which also prevents us from having a flow increase and for an induction of heterogeneous perfusion pattern, then we go for testing of viability. It doesn't mean, however, and that's a misunderstanding of that concept, that patients where we look for viability have no ischemia. Having hibernating myocardium means there is constant ischemia. There is all the time, whenever an oxygen consumption should increase, there is ischemia. And that's why they have repetitive stunning, and that's why they have hibernation. So they do have ischemia, but the flow is so low that, for example, with the SPECT, we cannot see that when we do stress the patient, there is even more perfusion abnormality, because it's just so abnormal that we cannot induce further abnormality. Just for the understanding, we do a viability testing, and we do it generally with FDG, and I would like to show you here a little bit of also the advantages of one over the other technique, without favoring one or the other, but there are reasons why we should know about both. If the test is positive, obviously we go for revascularization, because the goal of the viability diagnosis, and I have underlined diagnosis because in the next slide I will talk on the goals of the treatment, but first the diagnosis is to see viable myocytes, which are in akinetic regions, and then identify whole segments which are viable, non-contracting, and may improve their function. And then, of course, the aim is to, after that, have a diagnosis of patients or left ventricles which will improve the function, and where any measure of revascularization will have a prognostic beneficial impact. Now, the treatment goals are, of course, to restore the underperfused but viable myocardium, the flow in these segments, and to improve heart failure and angina, and to improve the systolic function, and to improve the patient's prognosis. Approximately 50 to 60% of the dysfunctional segments in patients with chronic CAD improve contractility after revascularization. That's quite a big number, and we would like to select really those who benefit most, because if they have a very low ejection fraction, their surgical peri-interventional risk is sky high, and we should really only put this risk on those patients who will have a benefit. Now, how is PET working in these patients? That's a symbolized cell. Usually the energy in myocytes is obtained by getting oxygen and using it in the beta oxidation in the mitochondria, and producing then energy plus CO2. Now, if the O2 delivery, if the oxygen supply is decreased, then the myocyte has the ability to change a little bit the balance towards more use, less use of fatty acids and more use of glucose, and then we have the glycolysis with lactate production, and so we change now a bit more into this axis here. Glucose uptake increases, and then we produce lactate in parallel, almost in parallel. There is no real constant rate here, but there is a parallelism between glucose uptake and F18 FDG uptake, which, as you all know, is then phosphorylized just once and then accumulated, while glucose is then going down the whole glycolysis. So we take advantage of the fact that cells which suffer from underperfusion or decreased oxygen delivery change their metabolism and accumulate FDG. That's the way it works. So FDG here is not at all a perfusion tracer. It is a metabolism tracer. It indicates that there are viable cells. But there is one crucial point to this, and that makes also different to the ease of use of MRI. We need insulin to get glucose into the cells. We need insulin to get F18 FDG into the cells. We don't need insulin to get glucose in the brain. There is no need. But in the muscles and in the myocytes, we need it. And if we don't have enough insulin, and I will show you what happens, what we do to get enough, we don't get these pictures. This is a classic picture of flow metabolism mismatch. It shows hibernating myocardium because we have here a perfusion abnormality with ammonia. Inferolateral, you see here the horizontal long axis, vertical long axis. Inferolateral perfusion abnormality, very low, but the FDG is normal because we offer the patients enough time to take up the FDG. It can drop by drop go to the lesions, and therefore, although a flow tracer will not get there because we use the protocols appropriate for flow tracers, the metabolism tracer will get there if the cells are viable, and it will take up a lot of oxygen. Now, this is a negative control patient who had an anteroapical scar, an aneurysmectomy, and a pericardial patch. So, by definition, certainly no viable tissue in the apex, and you clearly see that this apex doesn't have perfusion, and it doesn't have any sign of viable myocytes because there aren't any, because there is a patch. So this is a negative control. So there are considerations before we do prepare the patients, and the consideration is, because I showed you that we have a perfusion metabolism mismatch. Some centers tell me we just do FDG because we just look at the viability. Fine, but before you make a diagnosis of hibernating myocardium, you have to be sure that it is hibernating. So you need to know that it is not contracting, because it's very embarrassing if you come up and say, oh, I found hibernating myocardium, and then they say, oh, but it's contracting very normally. Well, how do you mean hibernating, you know? Because you think, oh, it's taking up FDG, so it's viable, and we mix up viability, hibernating, and non-contractility. So we have to be careful and to make sure that we know what we're talking about. I would like to see a non- or underperfused segment, so we need a perfusion test indicating this. Second, I would like to know that that specific segment, exactly the one which is underperfused, is not contracting well or is not contracting at all. So we would like to have some gated test which is linked to the perfusion. That is, I think, a very important part of it. Then I think that a stress MPI to identify reversible perfusion defect is helpful anyway, because if I can prove that there is an ischemia larger than 10%, this justifies revascularization. As I showed in the algorithm before, I have to test for ischemia first. If the ischemia is large enough, it justifies revascularization. If it's less than 10%, there is no good data to prove that ischemia should be, that this should be revascularized. There is no data at all for an active situation to prove that stenting is superior to medication, unless there is more than 10% and unless your FFR is pathologic, which shouldn't be measured, because I think we should do non-invasive testing before. FDG is not needed in moderate to large reversible perfusion defects. Another issue is, what kind of perfusion test do I need? And I showed you one with ammonia, which is nice if you have a cyclotron. You could use rubidium if you have a generator. It is certainly superior if you use a PET perfusion. If, however, you don't have this opportunity, then this option, then you use SPECT perfusion imaging. Now, there is the problem that if you're not using attenuation correction, you really do not just mix two technologies with different spatial resolutions, you also mix corrected images with uncorrected, and you might have then an attenuation artifact, which is then, of course, taking up FDG, and you think, oh, this is hibernating myocardium. Again, if there is an attenuation artifact, maybe it's not contracting there neither, because the contour detection is difficult. Watch out for this and use attenuation correction if you take SPECT. And I think that it is very important that the correlation with the ventricular function assessment is really done. It could be CMR, it could be, of course, gated SPECT, but best would be to have a PET perfusion, but we use technetium very, very often as well. Now, the pathophysiologic basis of the viability imaging that I have mentioned before, if oxygen delivery is decreased, then the glucose uptake goes up. But there is different traces. We mentioned ammonia, there is also water for perfusion, and there is FDG for the glucose. Now, what I would like to point out here is that we need an active GLUT1 and GLUT4 receptor. So in other terms, FDG doesn't just get into cells, it is insulin dependent. If there is insulin resistance, or if there is not a lot of intrinsic insulin, then we have a problem. And the heart can change, as I mentioned, a little bit, shift the substrate towards more fatty acid, towards more glucose use, and we have therefore thought, and many others have also been thinking about it, to use another substrate, another PET tracer. I have linked here, I have indicated here some of those which could be used, and the acetate is one of those tracers which is not dependent on insulin delivery and insulin resistance, and therefore that would be kind of a perfect tracer. If you look at this case, you can see that this patient has a non-uniform myocardial uptake of FDG, which is normal for healthy subject, can be mixed up with sarcoidosis, very difficult to differentiate. This patient in the fasting situation has an abnormality, a very strong heterogeneity in his FDG uptake. If you give glucose loading and then his insulin goes up, then you have a relatively homogeneous uptake. C11 acetate is not prone to this. It just goes into cells which are viable, and you have a very homogeneous picture. That would be the perfect tracer, but very difficult. C11, short half-life, you need a cyclotron around, and so no one is really using this, but that would be the perfect one. In reality, however, we use FDG, and for this, we have to keep the insulin as high as possible. We want to have high insulin. We don't want to have high glucose. Although we give a glucose load, we would like to have insulin as high as possible. Now, to give high insulin, we need to have high glucose. In healthy patients, you give glucose, insulin goes up. In diabetics, you give glucose, insulin doesn't go up, or is resistant. You have to give insulin. We would like to have very high insulin. So here there is the protocols that are suggested by the American Society of Nuclear Cardiology, and there is the option 1, which is the one which is most widely used. We are using it, oral glucose loading. The patient comes fasting, he gets glucose standardized, and then we measure how much it goes up, and then eventually we add some insulin. And that is the steps that we go through. It looks like a complicated thing, but in reality, it is very logical. You just keep the patient in step 1, you keep the patient fasting, and then you check the blood glucose, and according to the levels you have, you give more or less glucose loading. And if needed, there is a schematic, I'll just show you in a second, you add insulin. Type 2 diabetes patients can be very tricky. And there, certainly MR has big advantages, is not prone to any of these problems, may have other problems, but certainly this is not an issue with MR. You give then the FDG, and then you make an image acquisition. Sometimes in type 2 diabetes, I have almost no uptake in the myocardium. It's important that you tell your techs, show me the images immediately, because you can see this, and you can rescan. You can add insulin, and then you can rescan. Half-life is 2 hours, no problem. But if the patient has been sent home and is on his way somewhere in the Alps with no cellular connection in my country, you're in a tunnel somewhere, nowhere, you're lost, because you have to come back and re-inject FDG. If you wait and look at the pictures, re-inject and scan, you can solve the problem in most of the cases. This is one of those guidelines here to indicate that the higher the glucose after the glucose load, the more insulin you have to give IV to make sure that the glucose goes down again. But in reality, you want to have a lot of insulin, which improves your uptake of FDG. That's why you give glucose, because you want to have insulin high. And even a healthy volunteer, in a healthy patient, with regard to diabetes, glucose goes up, and then insulin goes up, and then your FDG is being taken up. So this is what you can find. There is 3 types of pattern. You can have a mismatch, which is indicating hibernation, low flow preserved FDG. That's the flow metabolism mismatch. That's what we would like to see. Then there is the transmural scar, which has low flow and low uptake, or no flow and no FDG uptake. This is a match. And then, of course, we have anything in between. We have a little bit of reduction in flow, but still we see a little bit there. We could measure it with PET and give a number, whether that would help here, I doubt. And you see here there is some FDG uptake. If it's more than 50% of the max, we consider this as still a little bit of viability, and then it will depend on many factors whether you would like to revascularize. Now, it came all from one study, and I would like to show it because this was the seminal work in New England Journal with a very limited number of patients. They looked at all the segments and looked whether they took up FDG or not, and then they looked if they revascularized them all, do they improve their function? And they realized, okay, if they take up FDG, they improve. If they do not take up FDG, they generally do not improve the function. And that's the sensitivity and specificity which they calculated. That's important because people will ask you, well, how sensitive and how specific is it? Well, this was the first pilot single-center, not randomized study, certainly overestimating the quality of this test, but it was paving the way for its use. This was one of the first trials here, and you see the years, 86, 97, so it took quite some years to build up the database, and this still is not an impressive number of patients, but was an excellent study from Rob Bienens from the Ottawa Heart Center. They looked at how many patients would change the treatment strategy if you use FDG, and they took those on a transplantation track, on a bypass track, and on a conservative treatment track, and then they realized that in 46% of the patients, the treatment strategy changed after doing a PET scan. Now this, however, does just mean that if you do an FDG PET, you change the treatment strategy. It doesn't mean that you do anything good to your patients. It just means you do a scan, you change the treatment strategy. It took a while to prove that this improves patients' outcome, and I would like to take you through the data of that. The options for chronic CAD and heart failure, if you prove that there is a scar, was medical therapy and heart transplant, and if you prove that there is viable tissue, it was revascularization, because the aim was to improve the function. And I would like also to take you through some of the thoughts of new results that this is one aspect, an important one, probably the most important one, but still, not only those who improve function have a benefit, even the others might have a benefit in terms of mortality, and I would like to explain you why. These were the first trials here showing in green the improvement in percentage action fraction, percent point, and all of them showed, although non-randomized, non-prospective randomized blinded trial, they all showed very optimistically, we have an improvement in left ventricular function if we do FDG testing and if we then revascularize. But most of them single-center studies, small numbers of patients, as you can see on the left side. That's why one of the studies was from Switzerland, because everything in Switzerland is small, even the studies. We don't have large patient cohorts. We cannot compete with the large US trials, but we can generate a little bit of hypothesis at least. One important aspect was that your extent of hibernation must have a certain extent to improve the function after revascularization. And in this 17-segment model here, it turned out that 4 segments, quite a lot, should be there to justify that you revascularize the patient. This is a very high bar to justify revascularization. If you look at the different technologies which can play a role in selection of the treatment strategy and in selection of the good patients, you will see that FDG PET is very much on the sensitive side, not so much, however, on the specific side. If you compare to low-dose dobutamine echo or MR or technetium tracers, they have a better specificity, but this seems to have a higher sensitivity. Whether this is good is another question, because if you detect many cases, but at the end your positive predictive your predictive value is not so high, and you revascularize them for nothing, there is just a few cells, that is problematic. Now here it's an interesting point, the comparison between MR and FDG, and I will come back at the end of my talk to this again. We did this 10 years ago. We had an MR here and a PET CT here, and we still have now 5 MRs here and 3 PET CTs here, and we will get a PET MR as well, but not because we are 100% sure that this is the future. If I would not have any PET CT and not any MR, and my choice, and I could freely choose between a PET MR and a PET CT plus an MR, I would of course go for this, because then I have a PET CT and an MR. And with the PET MR, I do not know exactly whether I could do all the daily business. But here we compared side by side, and then we fused it mentally, and we figured out that there is a relatively good correlation between the late enhancement and the non-enhanced segment versus the FDG uptake. I would like to show you later in my second part what kind of what kind of implications this has, and whether eventually there is complementary information that you could get out of that, and whether this could be helpful. But certainly for the heart, as the anatomy is not very complex, mental fusion or software fusion is perfectly good enough, and we do not need, for this kind of clinical applications, we do not need one hybrid machine, which is very expensive and is time consuming or blocking one each other. So we can do that on separate machines for sure.